them prior to Chris sharing them with you guys. No? Okay, sweet. I like when that happens because then it's new stuff. So my thought was, and I asked Chris beforehand to just give me a little bit of a ditty of what you got, because I'm the last one, right? Correct?
We have Terry Grindstaff, who's going to be the last guy next week.
Okay. But there were a few people before me, so I wanted to make sure that I wasn't repeating some of the stuff that you guys spoke about already. And I know Zach Baker probably did a really good job of just comprehensively going over stuff. So I think what made me gravitate towards these is that these two papers, and I came across them at separate times, months apart. And I immediately, after reading the second one about elevating the non-involved limb, I was like, oh, I feel like those two are pretty much really good complements, as almost like solutions for the one problem that Susan Sigward's article was highlighting. So I thought the two themselves could generate good discussion. They were both pretty small sample sizes, so I know that it might beg the question of some of how much in general research you can't lean too hard on any one thing, even if there are large sample sizes. So I thought that could be a good talk as well. But yeah, the other half was that I felt as though the non-involved elevating article was potentially a little bit more practical, could lead us to a conversation where people could take something from what we talk about and immediately try it, which is definitely a little bit of a pet peeve of mine in general about just, like reading research is 100% a good thing. Everyone should do it. I don't learn great from just reading stuff or being spoken to or spoken at. So I thought if we could use these two as more of like, I would rather speak less and have us all kind of chat as far as asking questions, but they definitely, they sparked some questions in my mind. So I was hoping that would be similar for you guys as well. And like I said, have it be something where you're like, okay, this is actually something I can potentially try with so-and-so, or maybe it's weeks down the road from now. But that was my hope.
Love it. That sounds great. Do you want to start with the compensatory one? Yeah.
So this one I think I originally heard about on a podcast, I want to say. So I'll actually throw this to you guys. I have a little bit of just a quick outline of recap. Do you guys want me to run through that really quickly, or do one of you want to do like relevant background information, methods, findings, whatever? Do you want me to run through that and then we can kind of talk about takeaways? Okay. I'm getting the half nods. I'll go with that.
Yeah, I'm going to be honest. I didn't get to read either of these papers, so I'm just here to...
Coming in hot, Shelb. Okay.
I know.
All right. So this will be perfect for those who either skimmed it or didn't get a chance to. So the other reason I like both of these is because I get really overwhelmed with some of the methods sometimes. And I know it is good to read through them so that you can actually see what they did. But I do tend to sometimes feel like I'm getting in the weeds there. And both of these, I feel like I didn't feel like that. So that was just another reason why. So compensatory strategies that reduce knee extensor demand during a bilateral squat change from 3 to 5 months following ACLR. So biggest things for me as far as in the beginning that they highlight, because I do think sometimes I learn a bit from the background info, so I like reading that as well. And then also what it leads me to do is look at their references, because when they make certain claims or throw some numbers out, I'm like, well, where did they get that? And then you can go through a huge rabbit hole in the references, but neither here nor there. So an average of 17% knee extensor moment deficits on the surgical side at 13 months post-op. So the reason that stood out and is important to me is because I feel like, any of you who have been working with this population or have in the past, that's probably not uncommon, and it kind of sucks that after a year, there's something greater than 10% as far as a deficit. And then also squatting is and should be used beginning early on in post-op, but bilateral tasks allow for undetectable intralimb compensations. Fairly well known, I think, but just a good reminder. Data have also shown that 1 to 2 years post-op, individuals reduce knee loading not only by offloading the other side, but also diverting force to the hip joint, and arguably ankle as well, but again, they're focusing mostly on hip. No changes in the force plate output, but differences in hip and knee extensor moments are the data that support this, meaning like the output is both still the same as far as pushing on the force plates, but when they looked at the kinematics or the actual joint torques at hip and knee, those were different, those flip-flops. So it's almost like an analogy that I thought of was like, you know, baseball players who have a crap ton of external and not a lot of internal, but they have the same overall arc. And then what they actually did here, took people ages 14 to 40. They were recruited from a single PT clinic where there were 4 PTs that agreed that their treatment followed standard rehab protocols. One of my least favorite terms ever, but it is, again, depending on what you're looking to study, it makes sense that in research when there's a bunch of other variables that they're not going to dive too deep into that. But what they did testing wise was they used a camera on motion picture, ground reaction force was obtained with 2 force plates during bilateral squat, and they took kinematic and kinetic data, that's both the force plate output and then the joint torques at the hip, knee, and I believe they also did ankle here too. They did also take isometric, they said it was isometric, and I got a little bit confused because they were saying it was different angles isometric. So either way, they were also just kind of circling back and making sure that there wasn't a glaring strength difference isometrically as far as max isometric contraction for either of those, because that obviously would have been the confounding variable. So what they found, significantly lower peak knee flexion angle on the surgical side. Basically, people don't like to squat as deep or bear weight on a bent knee on the surgical side. That's how my brain interpreted that. Lower peak knee extensor moment, lower vertical ground reaction force, and greater hip to knee ratio, meaning greater hip joint extensor net joint movement on the non-surgical side. At 3 months, lower ground reaction force ratios between the limbs, as well as that greater lingering, greater hip strength to knee strength is measured with the extension moment. That was actually predictive of smaller knee extension moments, obviously because the ratio is switched. And then at 5 months, it was more so just the hip to knee ratio as far as net joint movements that lingered as far as weaker. But again, I think their biggest point was that it does linger that long. So my major takeaways I have kind of listed out, but my thoughts, I want to just throw it to you guys really quick. Just initial thoughts after reading this. I want to kind of keep that part open-ended really quick, and then I can direct you. So anybody.
I mean, I just think I go back to like the whole like coach's eye thing, that you can like watch someone move and it might look good, but it doesn't mean that it is good at all. And then it's concerning to know how many clinics don't have a way to like actually measure this. We don't, like we have a handheld dynamometer. We just got a Biodex, and then we're just now getting force plates. So we've still cleared hundreds of ACLs over the past however many years, without knowing all this data.
But you couldn't even measure this without, so even if you had force plates, Biodex, handheld dynamometers, you can't do 3D motion analysis. And that's kind of the only way that you're getting at this data. Mm-hmm. So yeah, people might look good to you to the naked eye, but you're not picking up these things that persist and are greater than 15% probably deficit.
Right. But none of this is really new. Mm-hmm. I mean, they've quantified some things and they've put some time frames on some things, but these are known issues within ACL rehabilitation, right? And when they're saying at 13 months, right, we're kind of concerned about that because we're saying, well, at 12 months, they should be ready to return if they've passed all these things. One, we don't know if these people have passed everything, but two, we still have neurologic components within this, right? We have, obviously, if their quad strength isometrically is showing good, but these movement patterns aren't, and they've got aberrant movements, right? So we keep focusing on, let's get a quad strength limmetry or everything, but these are movement things. In movement, again, without a 3D motion analysis, our eyes aren't picking up some of the nuance, right? Mm-hmm. I say that, but that's in bilateral movements. Unilateral movements, it's a little bit easier, especially if you put an external constraint. I want your knee to touch this, I want to do that. So we're forcing some of the strategies that we want to see, right? And so I think it's how we're approaching things that this actually should be driving us a little bit differently to where we're choosing how we want to strengthen things, because we've got to move from isolated knee strength to kind of a movement pattern strength and what they're having to do and over various speed variables, because that's really where we're also going to have problems as well, right? And all these things are somewhat constrained in that we're not seeing at speed. We're not really seeing at high load. Neither one of these put them at a high load, right? And so there's multiple other variable factors that make it really hard to make a conclusion from these studies.
Well, and that's, I think, almost a microcosm of all research, right? So you can't actually make large conclusions. I think that you make a good point, Paul, about how, one, it's a reminder to make sure that we are early and often exposing them to single leg stuff, because athletes are really, really, really skilled at not just their sport, but at making shit look good. So they can probably lift pretty heavy and it'll look great. And if you know, what clinics have force plates and biodecks besides shelves? You know, like, not unless you're part of a big hospital system, you probably don't have that. And part of what's been hard for me, even around here in Boston, of all places, where there's a ton of medical centers, is figuring out places that do have this stuff and having a relationship with them. There's one, Children's has Biodex. They only use it for the bear procedure research. They don't even use it for the people that come back for their 6-month testing. They use handheld. And I'm like, how could you have this thing there and not even, like, people would pay to use that. I would send people and have them pay a fee to get it if I knew that I would. But anyway, I think that's a good reminder. And also that, again, this is something in clinic that, like, yes, we know we don't have a lot of times the means to measure it, but it means that if we know this is happening and that we can't pick up on it with our eyes, that from a programming perspective, because that's basically the tool that we have, right? As far as strengthening these kids and getting them, or individuals, and getting them back to what they want to do high level, then we need to always be cognizant of how they're doing stuff on, at least, what's the least we can do without measurements. See how strong they are on one leg, how controlled they are on one leg, and make sure that is always dosed into their programming.
I do find it interesting that this generation is moving back to biodex, right? Because when I started, one, we cut people out of cast for ACLs, but two, biodex was how we actually progressed people through. They had to test at certain phases, and then we moved away because it was non-functional, didn't give us measurements for what they're doing in return to sport. So we moved away from it, and now everybody's moving back to the biodex for testing at the variable speed. I just love how things are circular in our world.
What's the biodex in a nutshell?
It's isokinetic testing. So essentially, both handheld and like an inline dynamometer, like we have, is all MVIC basically. So max voluntary isometric contraction. You can do different angles at a time, but isokinetic will give you set different speeds. You can do a slower speed. Usually 180 is like the slowest, which is really hard, but you're sitting and you're strapped and you're fixated at hip and knee, and your angles are exactly 90 degrees, and they set the speed. You kick as hard as you can and pull as hard as you can, knee extension wise, and they're measuring output through that entire range. And then you can get a curve, and basically they can give you an output of what that leg, quad and hamstring wise, is outputting in real time through the entire arc of motion. So it's the gold standard, and it's really hard. That's what I mean. Like, I feel like something like handheld. The feedback I've gotten from some of my athletes that go, it's called the McKaylee Center, but it's part of Boston Children's, and they do hop testing and they do dynamometer testing, but they only do the handheld. And I had a kid come back to me yesterday and show me her thing, and she was like, it didn't seem hard enough. She was like, it didn't seem like, I felt like I was kind of rushed through it, and what we do in the clinic with you is like way harder, and I feel like it should be really hard. Like you should be gassed after doing your strength testing. So long story short, it looks like a really fancy knee extension machine that has a computer attached.
I think I've seen it. Yeah. I've seen, I always thought about it in like a research context, but well, people are putting them in like their clinic now.
I guess if you have the $40,000 or whatever.
Yeah. Yeah, I was gonna say, Travis, it's definitely 30 grand plus. So, and it is a large footprint in your clinic, and it also requires operator training. Like right now, I don't know exactly how to use one. So you would need someone to come in and train the staff that was going to do it as well. So it's
it's time dependent.
Exactly.
It takes time, right?
Yeah. So, but any other major takeaways before I move on?
Steph, and you had mentioned it, like they had called it like standard physical therapy or whatever.
Yeah.
Do you have in your mind what that kind of looks like, or your guess for this protocol, or is it just like so heterogeneous depending on the study that?
It's incredibly heterogeneous, but my guess is that I think the biggest consistency that I see in standard operating procedure is delay inappropriate loading. So the phase that is 4-way straight leg raise, TKEs with a band, bike for a while during the session, manual, like scar massage, that I feel like should be, and that initial phase of like decreased swelling, increased range of motion, and not a ton of loading to respect the joint healing process. I feel like it gets drawn out most cases for like 6 to 8 weeks, whereas at 4 weeks, I'm usually trying to see if people if they don't have meniscus or anything else concomitant, we're trying like mini squats and, even if it's just body weight stuff, by 4 weeks, I'm usually trying to get to that. And that is, based on some research, some mentor guidance, some experience, and the fact that there's a crap ton of research showing both hamstring and quad, but primarily quad, persistent weakness. So that's my hope as far as where I feel like standard operating procedure needs to start to bend or trend towards, just because they're already climbing up a steep hill. So if we can start that process a little earlier, then that's where I feel like right now the standard is just like that initial time frame is longer than it should be. After that, it's a circus. You can see all kinds of things. I definitely feel like there's a trend in the positive direction, but as far as from a protocol, it's very varied.
Yeah, I would hope that since they're doing research, that they're up on current application, but they didn't talk whether or not these people had passed return to play tests. They didn't give legs. I mean, there's a lot of missing data in this, right? Yep. Which made me question whether or not even that rehab was appropriate based off of what I would consider as true standards, right? Would
you expect them though to have passed return to play even at 5 months?
No, I mean, not at that, but they still went to where they were 13 months out and had, these deficits, and they're stating these things, and yet we don't know where these people are. Obviously not in the 3 month, 5 month that we're going to be doing hop testing and some of that kind of stuff with these individuals, but they could give us a measure of leg symmetry and some of these other kind of things of where they are, even if it's just a benign measurement at that point in time, right? And we don't even know.
Just to contextualize, right? Given that we would know what some of those other measurements would mean. The thing that's interesting to me is that there was no effective time, right? So you might expect these deficits at 3 months, but that they were still persisting at 5 months. And if you look at those plots, not a huge improvement.
Well, and that's the my other sort of hope with picking these, but particular Susans, is that it is helpful as far as a reminder that compensations happen that we can't see, like, yes, but also what are we doing in that 3 to 5 month period with people? Because 8 weeks of a good strength training program, you should see a difference between, like, to your point, Travis, like, I don't have athletes come in more than twice a week usually. But they are programmed at least 2 other days a week to do stuff on their own. And I put them on True Coach, even if they're PT patients and I'm not getting paid for it, because that's accountability. They have to check those things off and they have to report back to me. I actually make them, I don't know if this is me just being OCD or anal, but I make them film certain things. Like I'll say, you need to film this one. So even if they only did that exercise and just faked it and clicked off the rest, which most of them don't, but because they want to play. But even if they only did that, I'm like, okay, I know that they did Nordics. Or like, I know they did Nordics twice this week because they did it once with me and they filmed it with their brother or their sister. So that was another kind of hope as far as maybe lighting a fire for you guys, because there should definitely be a change between 3 and 5 months. Not necessarily astronomical, but it should be trending in the right direction, not be, you know, when you're around 6 months. I was just having this conversation with someone earlier who was asking me about Biodex info, and like at 6 months, there's really no data anytime before 9 months that says where people should be at as far as their limb symmetry index and their ham to quad ratios. And I was like, damn, you're right. It's probably because 1, they're so variable, and 2, we're so crappy at loading people that they don't really actually see a change until 9 months. So what if, hey, we were a little bit more diligent about, you know, single limb, bilateral limb, and consistent with volume training earlier on? Maybe we would be able to better test 6 months, and maybe we would be able to not necessarily return to full sport earlier, but be in a pretty good spot to start the return to sport process. That's my bias as far as how I refer to it, because most people are like, oh, they think return to sport means I could just go back. And I'm like, nah, it doesn't work that way. So that would be my other hope with seeing that no time effect. I saw that and I was like, oh.
So I was supposed to get lower quad in the summer, but we didn't, and because it was all online. So now I'm getting lower quad and axial in the 7-week sprints this semester, which is fun. But so I actually don't know like the standard, like what are PTs taught as far as expectations on ACL reconstruction, and like what like because I keep hearing like you say like, right, there's an underloading issue, but what is everyone taught? And then I obviously understand a little bit about the differences now, but what's the standard?
Well, I might actually first throw that out to the group, because you guys are closer to school. I can vouch and say that I was taught very little, but you can circle back to me. Does anyone who's closer to being into school or is in school, can you speak to that for Andy?
I would say we were taught pretty little on it as well. Body weight squatting was about as far as like our professor kind of covered. And I think he made mention of like, you know, that you should be progressing people to 50, 60, 70, 80% of their 1 rep max, but we never really went through like what that actually looks like. And then I remember for some odd reason, he was like very obsessed with single leg RDLs too. So he showed us how to do that one. And that was kind of the extent of it.
I'm a pretty recent new grad. I feel like the most of my last rotation was a sports clinic, so I felt like I learned most of that from that clinic versus the actual curriculum. So some of the stuff you guys see like firsthand, like the hopping test and all that stuff. So that's just kind of my.
So yours was more through exposure, kind of, not really directly in the curriculum.
Hi, my name is Selena.
You muted yourself again, Selena.
Sorry. Okay. Yeah, sorry. I just look like a hot mess, so that's just why I'm not. Yeah, like a hot mess.
Well, it's summer,
But
that's allowed.
I'm also like sitting in a dark room, so you won't even be able to see me anyway. Anyway, sorry. I went to the University of Delaware, and
The ACL
yeah,
capital.
yeah, they were wild about the ACL, but I think it was, I think it was really a fortunate opportunity because they had two biodexes
Yep.
in the clinic. And so we did a lot of discussion about NMES strengthening as well, and doing like burst testing and understanding the whole concept of activation of the quad too, because it may not necessarily be just strength that the patient is limited in, but also the fact, like, are they activating when their quad when they should be, and especially in their sport. And then we did a lot with perturbation training as well, which if you look that up on YouTube, it's actually really interesting. You can see a lot of the types of ACL rehab that they do, and that's not very, it's not $30,000, so it's a little bit more accessible and affordable. But yeah, sorry, hopefully that was helpful.
No, yeah, and I know that Lynn Snyder-Mackler has done and is a huge proponent of NMES. I definitely use that early on, but I think this could potentially be, a whole separate journal club in and of itself. But I've been diving a little bit more into the idea of AMI, or arthrogenic muscle inhibition, because totally will admit that I used to just kind of be like, oh, it can't linger that long. Like it can, and yeah, it can. And I'm anecdotally and diving a little bit more into the research, trying to check my own biases here. I realize that's very much so, I think it gets looped under that umbrella of it being like a neuromuscular issue or an activation issue. And I think for a while I didn't want to believe that, but, and, I don't think the NMES is the cure-all for that. But I do know and believe that Lynn and that team, they were and are onto something there. And AMI is something that I definitely want to better understand for those reasons, because I think that the other thing that the other article touches on that we'll get on to in a little bit here is that, is it, when we're looking at these strength deficits, is it really that they are offloading a side, or is it that that side is maximally loaded, but because of either atrophy and or things like AMI or other things that are inhibiting some of that neuromuscular side of things that we know lingers for 1-2+ years out, is it that is just not allowing all of, if we want to get into the weeds, like all muscle units to fire, and they just can't, it just doesn't have the capacity for the output. So that was the other thing that kind of made me go like, oh, well, yeah, maybe they are loading it as much as they can, and they just
Right.
want the capacity to create the same output.
Oh, absolutely. And
So
it's so multifactorial. Absolutely. Thank you.
yeah, good point.
I have something to add to Andy's thing earlier, and I have like 2 questions for you, Steph.
Yeah, go for it.
If it's not like too long. So Andy, I also feel like that most curriculums, they kind of like teach you kind of like the common ground, just because it's a lot of like ACL protocols out there. So they're probably gonna teach you stuff like from the Keisner and Kobe book or whatever. Just because it's like, I mean, the boards are gonna test you over the core material. So just because it's still like a topic that a lot of people are kind of delving into, they're just kind of, it's not like concrete information, if that makes sense. But that's my thoughts on that. And then, so one of my questions for you, Steph, is so say going back to the compensatory strategies. So say we have a squatter, for example, and they've been squatting for a while, and say they injure their ACL, whatever, on that limb. And I notice a lot of these like studies, they kind of like go over like knee and hip specifically, versus like maybe ankle, or even higher up along the upper trunk area. just because, usually when you weight shift, ankle might, pronate, supinate on, or pronate more on the one that you're trying to get away from, or like upper one side of your body is like taking more load, the bar is like shifted, whatever. So what if, during this healing process, the physiological adaptations are made, but then like to the person doing the movement, it doesn't feel the same way, and so that affects how they're producing that peak output, or et cetera. So I just kind of wonder what your thoughts are on that.
As far as, I just want to make sure I understand the question. So when they claim that it feels different? Yeah,
basically. So when, the healing phase is over and it's just like, they're returning to the movement that they were doing previously, but because it doesn't feel the same way, and this kind of goes back to that inhibition kind of.
Yeah, I think I understand what you're getting at. And that is another thing that seems to vary person to person a lot, because I almost categorize it in my mind, and I don't say this to them, obviously, but people will come up with really funky whole body patterns to figure out how to, A, offload an area that the body's not confident with loading, and B, complete the task and make it look good. So I do tell them that part, like, because I'll get anecdotally, I'll get like, I don't really, like, I feel it in my hamstrings and glutes when I'm doing a single leg deadlift on my left, but I don't feel it really much at all. I think I feel it more in like my back when I try it on my right, say that's their surgery side. So the first thing usually is I don't make a big deal of it, because they are already, you can tell they think something's wrong, right? But yes, I do see that pretty often. I will be honest that I think at that point, what we usually do is I will use, and again, this is more like strength and conditioning concepts, which is something I feel like all PTs, no matter who you treat, should have basic knowledge of, because what I'll usually do at that point, if we weren't already going to do that soon anyway, is I might just switch up the variation of said lift, or, like to Paul's point, sometimes use a different type of external cue, but I won't say anything, and just see how they navigate that new external cue. So if I had to give an example, and again, technically, the second article goes into almost an external cue, because you're just going to tell them to squat as they normally would, but now 1 foot's higher. So that is technically, could be adding like an external cue. But for instance, I have one athlete right now we switched over to Sumo Deadlift, because he is that quad dominant soccer player that just wants to squat everything. So any type of hinge that I've given him looks like a squat. And he's long, and he's got levers to control. So a lot of times, if I try an elevated sumo deadlift and have them try to keep their chest up, they have to, if they don't want to hit their knees on the bar every time they go up and down, they're going to have to shoot their butt back, and they're going to have to keep their chest upright, kind of thing. He found a way to not. So we were working the other day and I didn't say anything, but mid-set, I came up right in front of him, 3 feet away. I had a mask on, but came up right in front of him, and I was like, you can't touch me. Like, you can't. Like, and he's like, but over the course of like a set or two, he then was able to kind of like shoot knees out, come straight up and down. Now, again, that's not a specific thing for sport, but as far as being now able to load his hips and feel it the same, at least anecdotally, I didn't really do or say much of anything. I was just like, can't touch me, I'm just right here. I then put a roller in front of him for the next set because he was I think I made him uncomfortable. But that kind of stuff is probably how I would one, I do hear that, and two, I think I navigate that mostly with external cues or some sort of constraints. Sometimes that's really hard. I'm still learning on that end, but that's probably my best advice there. Did you have another one, Joey?
Got it. That was such a great answer. So,
well, we're going to be here for a little while, so if you think of it, let me know. Okay, so my next thought, unless anyone has anything to build off of that, was I know we talked a little bit about the strengths and weaknesses of the study in of itself, and I think the most important one of that was, aside from small sample size, they didn't give what standard procedure was, and the no real explanation. I think that would have tied in well with an explanation for explaining or alluding to correlation between not seeing any time difference between the 3 and 5 months. But my next question to throw out to you guys was what are some things you feel like you could do early on to promote loading or discourage the offloading of the surgery limb, even simply? So, they were talking about 3 months and beyond, but 3 months in the initial time frame is a long time. So are there people who have had some experience, or even just thinking hypothetically, what are some things we could do early on prior to when the person's able to squat that may set them up a little bit better to confidently load both sides a little bit more equally? We know it's not going to be exactly equally.
Well, obviously there's the foot on the step that we're going to talk about, but another way that you could get at that instead of changing the person's position would be off uneven loading of a bar, or a goblet squat with the kettlebell holding it on one side instead of both hands. Try to shift the load onto that leg.
Yeah. What about even earlier on, like before they can, because those, I mean, actually that's a really good point. I didn't even think about that as far as even concurrently with a bilateral squat, like maybe some of your accessories, if you will, or your smaller supersets after you do something like a squat or a deadlift,
just do extra volume of your TKEs or something like that well, I guess you would only be doing your turn on the extensions on the affected side. Is that right?
I'm a little anal. I do everything on both sides. That's
yeah,
also,
then maybe extra volume on the affected side.
Yeah, like an added set or something like that. Yeah, fair.
Maybe suggesting like when they come to stand out of a chair, like which they'll do like often several times a day, have them kick out the uninvolved side, so that when they stand up out of the chair, they're loading the involved side a little bit more.
Yeah, so they're even getting quote unquote reps of that at home, just like daily.
Yeah, I like that.
Yeah,
I like that a lot.
Or, is it okay if I say one more?
Yeah, go for it.
Okay. Maybe like when they're like brushing their teeth, they can just put their uninvolved leg on a step, and then, so not really doing the squat, but they're getting that weight bearing in standing a little bit more on the
I'm a big brushing your teeth person. So not, and by that I mean
me too.
By that I mean even for other diagnoses like after knee replacement, or somebody with low back pain even that doesn't tolerate just bilateral axial loading. Thank you, Shel. But like being able to shift weight and get more comfortable just loading one side, I think there's a lot to be said about that. And as far as early on goes, is if their weight bearing is tolerated right after surgery, like just say, you brush your teeth twice a day, right? So pick one. In the morning, you stand on one leg, or you shift over to one leg and stay there for whatever, a minute and a half, 2 minutes while you're doing it. And then the other side. I think that's really awesome. And I think that I'm also guilty a lot of times of overthinking things, in the sense of like, there's a lot of little ways, even just with ADLs, that you can promote more comfort with loading that side, literally from like week 1 or week 2.
And when you anchor it to habits that are already formed, right? So that those nice triggers for those habits that are already there. So you just anchor to various triggers. Right, exactly. Here's what you do with those things. And that helps them remember, oh, this is what, and those are already habits that are ingrained. And so it's easier to get them to do some of those kind of things.
The other thing I will go, Shell.
I was just gonna say one other thing that I'll have them do like before like loading them up is just like, instead of just doing like a regular box squat, is basically having them sit on the box with their uninvolved side basically completely off the box, and then going box squat, so that if they try to shift over to their uninvolved, they're literally not gonna. They're gonna fall. Yeah.
No, I like that. I think one of the other things, this is kind of like a part B to early on being comfortable with loading, and something I have to give some credit to Wes Wang for, because what I was seeing both in the squat and the deadlift, you know, closer to the 8-12 weeks and beyond, with the shifting, I started to realize I don't think it's because it looks as though when it's bilateral that it's a hip issue, like they're doing like a hip hike. But when you look like kind of to the side and you correlate it with some of the other single leg tasks that you realize they can't do with as much of a bent knee, which is also a pattern we know that we see after ACL, they just don't, they don't either land or they don't tolerate bearing weight on a bent knee at greater angles. So started to realize, like, I don't think this is a hip thing. I think it's that they get to a point where they don't want to bend the knee anymore under load, and so the hip pops up so that they can reach the floor in a deadlift or they can reach depth in a squat. So one of the things I started doing over the last year or two is, in addition to those things like the ADLs and maybe some more volume of certain single leg stuff on one side early on, is actually making people bear weight on a slightly bent knee within comfort range. But like if you're doing some single leg stance stuff, like say, let your knee unlock, like just, and hold it. Or the nice thing is, obviously that's super boring, something you can do at home. But do you guys know what, and this is, I think, named by Wes, and that's who I stole it from. Do you know what the Captain Morgan exercise is? So standing perpendicular to the wall, there's an exercise ball, like one of the big balls, between the wall and the leg closest to the wall. That leg is up, is bent, is off the floor, and pushing into the wall. The other leg, the stance leg, so one is here. I can show you guys a video, but basically your slightly bent knee on that outside leg, the inside leg is pushing against the wall, but you're still bearing all weight on the outside leg, and that leg is slightly bent. So you are now working a lot. It's kind of big glute med, but the stance leg is also really working on, you have to hold in a bent knee position. And that one is a really good position to distract people in, meaning they have to hold that, but while they're in like an isometric Captain Morgan, you throw the ball or you do some other thing for counting so that they don't even realize it, but they are now bearing weight on a bent knee. Other versions of bearing weight on a bent knee is like a lateral heel tap, like the going down the stairs thing, except for people don't always tolerate that as well. So I feel like adding things in where you can distract them a little bit is huge. Has anyone else had experience with people not liking bearing weight on a bent knee? What has been some of your strategies?
I feel like, yeah, sometimes they'll use almost like a hydrant hold to just have them like real simple, like band around the knees, be in like a unlocked knee position for a set period of time. So starting at 15 seconds, whatever they can handle, and just literally having them hold that position. So similar to a Captain Morgan, just kind of without the wall and the ball. Yeah.
I kind of find myself putting a lot of like safety nets in place, like maybe have them doing it holding the TRX straps, and then maybe also like putting a box underneath them. So, and just saying like, so if you do need to sit down, you can just easily plop down onto the box. It's not going to be like you're going to hurt yourself or anything.
I like that. I mean, again, some of those constraints, sometimes it's helpful constraints, right? So we're not just constraining a movement, but we're allowing the body to express things because it's no longer fearful in that, right? And so the CNS inhibition isn't limiting as much because it's feeling a little more comfortable, right? And I liked how Steph earlier said they feel comfortable expressing something, right? Well, that's really what it is they have to feel comfortable expressing. They have to feel competent in that movement. And sometimes giving them a little either offload or just the balance component allows them to use a better knee strategy than a hip strategy, et cetera, right? So sometimes it's giving them the external constraint, but it's actually a helping constraint rather than a limiting constraint, but allows the expression that we're looking for from the body, and then dosing that up as we go. And so it's finding where that rate limiter is and then eliminating that rate limiter.
I have a quick question, maybe for Steph or for anybody, Paul, or anybody else. I find myself a lot of times, like whenever I'm trying to get patients to use a more quad dominant strategy for like an exercise we might be doing, I tend to find myself like telling them, try to like feel it in your quad. And I know there's a lot of like debate as to like, you know, how much maybe contraction are you actually producing, but like I'll have them perform it one way and then kind of have them perform it another way that might be more like quad dominant. Say like, do you feel the difference there? And then try to have them recreate that in some of the movements. Do y'all ever find yourself doing that, or do you think that that's a useful strategy?
I'm going to divert to the group first.
Yeah.
Internal versus external cueing, right? And internal cueing isn't bad, right? It can be helpful, but the external cueing oftentimes is being shown to possibly lead to a different thing, right? So whether it be constraining so their hip can't shoot back by putting up closer to a wall, or giving them a target to reach to with their knee, those things tend to lead to, in the literature, right, a different outcome, because people, again, we suck at knowing where we are in space oftentimes, right? Or we're great, the body is great at tricking us into believing that we're doing something right? And so oftentimes giving them that cue constrains and gives them the controls that they actually are looking for.
Mm-hmm. I guess I feel like I do it because sometimes when I put a lot of external cues on them, I feel like maybe the way I'm doing it is not challenging them enough. And I guess in my own training and exercise, like I kind of find myself trying to get to that like max fatigue level that I can, or as close to it as I can. And I guess I almost feel like unless they are perceiving like when they reach that sort of thing, then I may not be pushing them as hard as I could. Does that make sense?
I understand. You're trying to reach that where you're getting to an effective dose, right?
Yeah.
Right. And so that's how you're feeling it. And so that's feeling, but that's training, right? You're teaching them how to train, right? So the constraint should be early. And then as they start to learn that movement, gain competence, then you take away some more constraints and you start to load that as they become competent. And that's where they're going to start to feel it. If we're still using constraints way on with heavy load, they haven't shown the competency, and we probably shouldn't be loading them yet, right?
Gotcha. Yeah.
Alex, let me ask you this, and then Shelb, I know you were gonna give one of your strategies too, so don't let me forget. But does that feeling it in the quad have to happen in a squat per se? So my challenge there would be, I agree with you. Sometimes they're not going to feel it in maximally in something like a squat, or maybe even a split squat, or maybe even a single leg squat, because they might be out of their control, diverting a lot towards hip musculature. But within the same session, are there not other things you could do that are really gonna like burn the quad?
Yeah.
So
sure.
if they're struggling with that for a little while, I'll just make sure that I'm adding in, like, maybe if we're really having trouble loading and feeling it there, or feeling like we're getting a stimulus and the atrophy is lingering and all that kind of stuff, bearing weight on a bent knee, still not confident and wobbly with, like, we're probably going to do end most sessions with like BFR and doing like leg extensions or something like that's literally just going to gas the quad. There are other ways to get a stimulus, and I think that once I kind of like wrapped my head around that was huge, because there's very few in the population that I work with. It's usually adolescent females. So they're just learning how to actually squat without like, I mean, you know what sometimes you guys see, it's like, oh, okay. And that's okay. Like, I don't downplay that, but I feel like the training age of individuals I'm getting is so low anyway, that I think I started to not harp as much on what they were feeling, those bilateral movements, because they don't really know what the hell they're feeling. to put it lightly. So I just kind of, as far as from the supplemental side, like you can rest assured, get the stimulus in that session that you want for said muscle group that is or where weakness is lingering or is a little behind, and doesn't necessarily have to be in some of those compound or bilateral movements, if that helps.
Yeah, definitely.
Are you looking at training effect, metabolic stress, or are you looking at movement effect, right? And so those are slightly different conversations in general as well.
Yeah. Okay. Thank you.
Yeah. Shell, what were you going to say?
No, I was just going to say, I don't think there's anything wrong with wanting to draw attention to how like a movement that is more, quad dominant versus a movement that's more hip dominant, just drawing patient's attention to like, do you understand like how this feels different? Because that can be something you pull from like later on. But I also think, their perception of where they feel it could just be, if they're saying they're feeling it in their hams and they should be feeling it in their quads, it doesn't mean that their quad is not doing what it's supposed to be doing. And I think that's kind of where I wrestle with that. But yeah, I mean, I was just going to say like, having them go through like a slow tempo, like kickstand deadlift early on of just like, okay, so like we're going to do this for like 30 seconds straight. And then having them do like, once they're able to do some kind of like split squat, like isometric hold for 30 seconds and just drawing attention to like, do you feel the difference between, exercise A and B? But beyond that, yeah, I don't think that's like a bad thing at all. I would just kind of echo what Paul and Steph have already said as far as get your quads in other ways, and then it'll come along, or even like putting them in like a heel elevated position where they have to load their quads, so you don't have to like bring attention to it at all.
Yeah, I really like a couple of things you said, Shelby. Like you can manipulate the task by, say, elevating their heels, so it's going to bias the quads without, first maybe you just try, okay, touch their quads and say, do you feel it here? That might increase the connection, change their position, slow down the tempo. That could, like you said, that could do the trick. But also to Steph's point, like, okay, maybe it's not that important because we know the quads have to be working in a squat, even if they feel it more in their hamstrings. But like you said, Steph, well, maybe we're going to burn the quads out with leg extensions at the end. Well, you could also switch that in like the bodybuilder pre-exhaust.
Yeah.
Let's do our leg extensions first, and not necessarily to all out failure like we would at the end when they didn't have to do anything after, but just to get them feeling the burn in that spot, so that then when you go into the compounder, the squat multi-joint exercise, you can say, okay, remember what you were feeling in the quads. Just try to connect mind to muscle when you're going into that compound exercise.
And if you do, I'll say one last thing, and then I think if you guys are cool, we can go to the next article. But if you do feel as though your clinical judgment is telling you that it is important to see if they can, whatever you want to call it. I'm not a huge fan of the word activate, but if you're feeling like you want to teach them how to, or you want them to feel that activation in a bilateral task, things we have had success with are like, and Shelby alluded to it, doing things continuously at a slow tempo for 30 seconds on, 30 seconds off. What we learned from Scott Morrison as far as doing something like oxidative, you're going through middle 80% of the range, under load, really slow tempo, full time under tension for 30 seconds. We've been doing that with a little weighted wall squat. It looks like a wall sit, but you're just going up and down. And I have yet to meet a person who has not felt that in their quads for 3 or 4 rounds, and that's a bilateral task. And you can even bias that one with putting their heels up on a couple of change plates, and you don't need a ton of load. You add BFR to that, they might not like you, but it's again something that's a bilateral task now that you can potentially elicit some of that mind-muscle connection that maybe you're looking for without saying like, okay, imagine that those muscles are working and try and turn them on, because we know it doesn't really work that way. Does that make sense? Does that help? All right. So I actually have to give my boy Cody Mizuraka credit for this one. I think he posted this on his story or something a few months ago, and I was like, I need that because it was in I think it was the Journal of Strength and Conditioning. I didn't have access, so he had the PDF. Got it on the black market, basically. And I had, ironically, just started trying with just, in this article, what was I going to say? Oh, in this article, they used like a really high, for me, I thought that 5 centimeters was really high as far as elevation. I had been putting like literally a 5-pound or 10-pound change plate underneath one of my athletes, because I kept getting the report of, I don't really feel it on that side. And we were still doing single leg stuff, but it seemed to be a concern of hers. Because of everything we just talked about, I wasn't super concerned about it. She was very concerned about it. She's a little bit psycho. She's one of those people where I have to actually put 5 days in True Coach, because if I don't, she's going to overdo way whatever. I spend so much time programming for this girl. I love her. She's going to do great. But she was very concerned about not feeling it. So I'm like, all right, I got to play into this a little bit. So I started putting under the uninvolved side, like just a little plate, both with the deadlift and the I didn't really let's just try this and see if it, if the body wants to shift away from that side. So let's see if this helps just shift it back over and she loved it. So we were using it a little bit, and then it got me thinking a little bit. And then literally like a week later, Cody posted this article, and I was like, oh, I'm a genius, right? I probably had seen it somewhere else. I don't remember. But again, the sample size, pretty small, not something you love to see, but I liked that it was 5 females and 1 male, just saying. Interesting also that the time from surgery to when they did this testing was anywhere from 7 weeks to 6 years. So again, similar to what we were talking about, like what Travis alluded to, the time difference in the other one is that these types of compensations / remedies for them are things that we're not just talking about in the first, 3 to 6 months. They can potentially be helpful / linger for much longer than that. So, and again, who knows what their standard procedure was. Ankle, hip, and knee net joint moments were calculated, as well as kinetics, with 2 test scenarios, one with both feet on the floor, the other with the uninvolved limb elevated 5 centimeters. I thought this was interesting, and I'm curious if anybody else has seen this in the past with different procedures, but they had the person hold the weight over their head.
I was just looking at that. That's why I had a cowl on my.
Travis, have you seen that?
Yeah, what I had seen that before, it was so you know how squat like a baby, because babies have really heavy heads. I've never tried it with anybody, but I've been meaning to. Apparently, for people who are really struggling to learn to squat, adding the weight in that position can just be like an instant game changer.
Okay. We'll see.
It's center line, right? Center of mass, instead of it being anterior, which they're tending to lean forward and shift the hips back. So this keeps it a little more. It's like an overhead, but you don't have to have the shoulder control.
You don't have to have the shoulder mobility.
Right.
Okay. Learn something new. Okay. Glad I asked. I thought it was maybe just that, like, sometimes when there's foreign researchers, you just think like, oh, do people just squat weird over there? Like, I don't know. Don't tell anyone I thought that.
How heavy is that plate?
I think it was pretty light. They were talking about that they didn't max over. I don't think they even said.
I can't find like the weight. I was just curious.
I think they did. It was 10 and 15 kilograms.
Kilograms. Yep.
Yeah.
Okay.
Female and male.
So not more than 20 or 30 pounds.
Still a lot to put on your head, kind of.
Top of your head, yeah. I'm not gonna lie.
If you haven't trained it, it's uncomfortable for sure.
Yeah.
6 plates.
And they did allude to, I'm sure we'll get into this, but they did allude to, like, potentially data would have been a little bit different if they were maximally loaded in some way. And the other study that they reference a lot, Salem, they found similar findings, but they used a barbell. So I think I would be biased towards, but
Salem said the current study and that of Salem used relatively low loads as well. So I think it was still barbell, but it was still, I think, relatively low compared to max.
Yeah, so I think similar. I mean, I think my bias would be like, and they alluded to this in the strengths and weaknesses, but to investigate a little bit more what higher loads would do, because I think ideally, if it was showing a more even output with ground reaction force and joint torques or joint moments with not a ton of weight, would that discrepancy continue to decrease with higher loads? Or again, because it's higher loads, you would see it go the other way? I actually don't know that answer, and the reason that my mind went there is because I ended up having a high hamstring strain, like really bad high hammy tendinopathy, like over the last year, after I started doing basically all powerlifting, after being mostly a runner, and I could over time literally feel during max effort I was shifting over to my left. But at lower loads it didn't matter. So that's what made me think about that. And again, I think we can circle back around, but I wonder what higher loads would do as far as that trend.
I wonder about that too, and I also wonder about higher reps. So, sets of 2 or 3.
Right.
And it was the same in this study and the other study, or maybe it was 5. It's like those are neither the loads nor the rep ranges that people are using in practice. So you can imagine that these things would be exacerbated when you get to fatigue, but we don't know for sure.
Right. Yeah, I'd love to see the fatigue and the load. And if you talk to a weightlifter, oftentimes they say that they need a certain load to get to a certain depth and to normalize things, right? So maybe some of these things that light load clear out, and then as they get heavier or more fatigued, it shows back up. We don't know, right? So I'd love to see those trends and actually look at some of that load and differences.
What do you guys think? Do you guys want to do a study?
If we only need 6 people, we're ready to go.
I know, right? If the effect size
how
in the
many people
population
tore their ACLs in here?
Yeah, actually, how many do we have? Did anyone besides me?
See you. Thanks.
Oh. Taylor, Rita, Laura, no?
No, not yet.
No.
Don't say yet. All
He's
right,
got a mindset, right?
I got goals.
Oh, all right. So their major findings were a decrease in vertical ground reaction force in the involved limb compared to the uninvolved in a normal squat, which we kind of assumed. The involved limb vertical ground reaction force was greater than the uninvolved in some cases in the experimental squat. So sometimes not only did this discrepancy even out, but that side ended up actually outputting more via the force plates. The involved knee extension net joint moment was near even with the knee extension net joint moment in the uninvolved limb when the uninvolved was elevated. So sounds similar for ground reaction force and net joint moment, but with the ground reaction force, they were even if not greater in the involved limb with the experimental situation set up, or the uninvolved elevated with that 5 centimeter platform. And then as far as the knee extensor net joint moments, they were also almost even, and then in some cases slightly greater with that side elevated. And then there's an increase in knee extensor net joint moment in the involved limb when the uninvolved limb was elevated as compared to in the normal squat. So they wanted to clarify that it was different than when it was in the normal squat. This was interesting. I think my biggest thing was what I asked earlier, as far as from what could direct me most clinically or make me critically think about what matters. And I think that that's a loaded question because we're not sure whatever matters, but was the decrease in the discrepancy of the knee extensor net joint moment due in larger part to a decrease in the uninvolved net joint moment, or in larger part to an increase in the involved knee net joint moment? And the part B to that is either way, what does it expose and does it matter? So I know that's a little bit loaded, but what do you think?
Well, I guess I have like a bigger overarching question. When I looked at this paper of like, I guess it's two questions. One, do you even need to like have a bilateral sagittal squat to feel confident about return to sport for ACL? And if not, why couldn't you just, like, if the main goal with this is to just get more quad strength and force production on that limb, why couldn't you do like a rear foot elevated split squat or a front foot? Like, I don't understand. It's almost like you're trying to shove like a square peg into a round hole with this. And it's like, it's the bias of we need to have them do some type of bilateral squat. So the one way to fix this is we elevate that foot. So my question is this even necessary, or could you just do other exercises to get the same goal?
Sam, what do you think?
I sort of saw this as similar to a kickstand or a B stance, just another way of biasing one leg when you're doing a somewhat bilateral exercise.
Mm-hmm.
So, but I don't know if it's like, well, all of our bilateral squats are not going to be like this, or what? Like, when does it end, right?
Yep.
Do you need it forever?
Right. Are we biasing towards one limb? If that's our purpose, then could we not load it more effectively in a single limb type exercise, right? Now, I understand we're trying to smooth out and equalize a bilateral movement to a degree, but again, this is just another kind of constraint-based type programming, right? That eventually we go from maybe 5 centimeters, 4 centimeters, 3 centimeters, 2 centimeters, but again, our eyes can't see that, right? So that we have to be in this research program to be able to apply this level of technology, right, at this level of constraint, to know that we're getting those things. So for me, my bias would be I'm single legging most of these people if I really want that to dose at a training level for this. Plus, I'm not sure how many of us have people go ass to grass in their regular programming for like a field sport or one of those other kind of things, right?
Mm-mm.
And these look like they're ass to grass in the pictures. So
So follow-up question to that. So if we're assuming that most of these athletes are going to have to go back to bilateral squatting for the purpose of being an athlete in like a school setting, and that's like part of their programming.
Yeah, college kids will have to do that. Yeah.
Yeah. So like it is valuable in that sense that like this is a task they're going to have to get back to. But do y'all have a certain like limb symmetry cutoff that you're looking for before you start like really loading up a bilateral squat? Like if they're at 50% limb symmetry, how effective is a barbell squat versus if they're, maybe like 85%, and then we start loading them up bilaterally? Or like, how do y'all balance like bilateral and unilateral kind of through those first like 4 months?
I think it's tough because I for sure start squatting people, not necessarily with the bar because not everybody training age wise is appropriate for that. But it is a little bit of a gray area, I think, because I do want people bilateral squatting, even if it's elevated. Like we have a 20, 24, and 30 inch rogue box. So even somebody who's only like 5'8", and they might get through the first maybe 60 degrees of a squat, and they're not shifting crazy amounts, they're probably squatting with a little bit of load by week 4. So essentially, obviously I'm not going to do dynamometer testing before a month with them. It's not appropriate because I'm not doing a ton of loaded open chain before then either. But I do think that before I'm comfortable pressing the gas on load with somebody who is barbell squatting, I would like to do a follow-up strength test, which I usually do for the first time at about 3 months, as long as they can tolerate that, 12 to 14 weeks, around the time that potentially, if there's no other hiccups and no post meniscus injury, that we might be doing some lower level plyos and pre-running stuff. But I'm curious what other people sort of think about that, because I'm always open to.
I just have a strong bias towards, one, I use goblet squats a lot, right, as a way to clean up some of those. And then I squat to box height, right, so that we can show competency through, and then just staging that as much as I can in a progressive mode, right? And so I'm allowing their body to tell me that, because again, training ages are all over. We're very disparate in how well we move just in general. And so if I can anteriorly load when I'm getting maybe a little more quad, right? But typically I get a more upright body and I'm getting a little more controls, and then I just kind of dose that over through a range of motion, increasing the range as they get a little more competent, right? And so we play with that and just see where they fall based off of how they're moving. And I start that pretty early.
Good, Chris.
Steph, to the point that you and Shelby made of, for sure, they're probably going to be asked to bilaterally like barbell squat in some capacity in high school or college. If they didn't, is there a reason to perform back squats or front squats with an athletic population?
Front squat meaning all with the bar, or are you saying in general, even with
like a barbell type of squat? What would be the purpose as compared to like any other type of lower limb exercise?
being able to get enough load, to be entirely honest. You hit a ceiling with kettlebells and dumbbells as far as how you can hold them. So what I'm seeing, if I can and they are appropriate and their goals are lofty as far as getting back to a higher level sport, even if that is just a high school sport, because I consider that high level, they need to be loaded more than what they can hold in their hand. And what I'm seeing as far as, I have 3 athletes right now that I have pre-op data on, which is awesome. And I'm hoping to continue to do that. We don't always, unfortunately, get people beforehand. Sometimes they're just like, yeah, I had surgery a couple weeks ago. Hi. And you're like, oh God. But in that case, what I've already learned a ton about is that their strength prior to, especially high school kids, they were pretty low. Even elite level kids. So again, they're really good at playing their sport all year round and doing skill work, and their endurance is great. But some of the basics like strength are potentially how they ended up in the office. One of the pieces of the puzzle.
What are we talking as far as those pre-surgical numbers? Yeah.
I had one girl who ham and quad number out, and ours measures poundage. So it's not, and a lot of times, like other handhelds will give you newtons and then you calculate torque. We literally just go by pounds to get a ratio. And I like to compare that to their body weight. And her output, hamstrings was in the, hang on, I'll tell you right now.
You're measuring them in prone 90 degrees?
No, we do both in sitting at 90 and 60 degrees.
Just pulling.
Yeah, we fixate hips and knees, and we take out slack with bands. It's pretty, I guess, margin of error. We've, over a lot of versions of it, a lot of tries, I think we've been able to decrease that. But hers, because she's coming in next week, so I just had this pulled up. This would actually be good. So her pre-op data. So this was in January. Her surgery was at the end of February. Pre-op data at the end of January. Her quad numbers at 60 degrees, so mid-range, where they're strongest. Her surgery side, the average was 92 pounds, and the non-surgery side was 82. She probably weighs like 120. Hamstrings. Oh wait, I'm sorry. That was 90-degree quads.
The surgery side was stronger?
Yeah, she's right dominant soccer player. So I don't often, that's not crazy abnormal, but they were equal at 60 degrees. It was 116 and 115. So that made more sense. Sometimes the end ranges, people have a discrepancy more so. But her hamstrings at mid-range were 52 and 56 pounds. Prone would actually probably be less because prone's harder to generate force. And it would be that we can't use the inline. We'd have to do handheld for that. And that's a little less accurate. So that's why I like to do the sitting one. But that's really low. So in general, I think back to your point, Chris, like at least with what I have access to and what I know right now, if they are tolerating something like barbell wall, we're lucky enough to have a safety squat bar too. So for people that really just can't figure out the shoulder thing and it bothers them and they do something funky, the SSB is kind of nice because even though it is a bit more quad dominant, it does allow them to load up the squat pattern a little bit more. And it's almost a little easier for doing things like when we want to start biasing towards power a little bit, you go slow down and then you explode up kind of thing under load. Because that's the stuff that, I mean, I don't need to do anything less than like probably 4 or 5 reps with a field or court sport athlete. They don't need that. They need repeated sprintability. They need power. They need endurance. They need to be able to do explosive things with minimal rest. So that's my long-winded answer, but I think if I were to put it simply, it's just because so much of what I see is just that they're starting from so low that if I have a means to load them enough consistently, then that's what I'm going to do.
Quick question, Steph. What do you want hamstring quad ratio to be at? Is it like greater than 60 or 75% or something like that?
The which ratio? The
hamstring quad on same leg.
Yeah, so that's also something I've been having an internal battle with a little bit, and talking to some mentors because I originally had like really lofty goals of it being like above 90%, and I know that would be great, and that's really what we shoot for limb symmetry is to be above 90 if they've had history of injury or if they had other complications. I'd really want to see it even higher than that for like quad to quad and ham to ham. But I'm learning both from having more data over the last year with the dynamometer and from reading and from talking to people that I think the hamstring to quad, especially for the population that I work with, it might be more realistic to be more like 80, like above 70. You definitely want above 70, but and I'm curious to hear what other people have heard too, because I'm just finding it so hard to get ham to quad to 90% even a year plus out with somebody who's been with me and consistently training that whole time.
Yeah, we have a handheld dynamometer that we've used in our clinic. Well, I'm kind of the only one that uses it, but I've been trying to use it with one girl that I have that's post-op ACL, and I think she's at like 60 right now. And I've mostly just been referencing, I mean, I've used a lot of other stuff, but mostly referencing for ratios, Nev PTs, ACL protocol. And I think at like 7 or 8 months, he wants it above like at least 60 or 75%. So I wasn't quite sure exactly like how high or how close you want that to get. So we've been like striving towards that. I was just curious what you typically shoot for as well.
Yeah, I would just like to see and that's also including everything else looking good. So they're moving well, they're psychologically in a good place. They have really good single leg control, acceleration, deceleration, change of direction looks on point. Their cardiovascular and like conditioning is great, and they just overall feel ready to go. If they're closer to the 2/3 with ham to quad, and the limb symmetry index for quad to quad and hamstring to hamstring are also really good, I have a hard time telling that kid that they can't start to ramp up back to sport, because a lot of times what you'll see is if they continue to strength train during their return to sport, sometimes that stuff starts to even out a little bit.
Steph, you said that Boston Children's is the dynamometer or the Biodex.
Yeah.
When are you referring out to have athletes go there instead of just doing the testing that you have in clinic?
I don't anymore. Because I can't, like if I had access to their Biodex, and again, I'll keep nudging them, but if I had access to the Biodex, I would probably do 6, 9, and 12, because in between those times, I can get touch points with our dynamometer that would be, and from what I've gathered, if we're doing things the best we can as far as decreasing margin of error with the setup and making sure there's no lag when people are doing their contractions, and making sure the whole setup and rest time in between is with a timer, everything's the same. Our findings are pretty similar to, or should be pretty similar to what they would find with something like isokinetic. Theirs is just they get more data because they go through the entire range, so they can get a real time like curve versus just snapshots of different parts of the range of motion.
Do they do Reynolds?
Huh?
Do they do Reynolds?
I don't know, man.
Like running time? I mean, hospital systems typically, because return to sport testing has a liability, they're liability fearful, right?
Right.
And so oftentimes they'll do that. But if they allow you to do the testing, you could drive a whole business of just doing return to sport testing if you're willing to take that and just rent time on the device rather than referring out.
I didn't think about that. I don't know how to use it, but I guess I could learn. And I did used to, oh God, I think it was my first or second clinical. They had one at the place I was at, and I wasn't actually allowed to operate it, but that was probably a liability on myself. But I watched it a lot, and I had a pretty good sense. But that was.
I think when it's working, it's not that difficult. But if you have to troubleshoot it, then that's where it gets complicated.
Yeah. Yeah. No, I can look into that. That's a good point, Paul. But yeah, that's not atypical. Those numbers that I was just talking about are not atypical as far as output for a lot of who we see, because they just tend to be the local high school athletes. But
Shelby, did you say you have a biodex at y'all's clinic?
Yes, we just got one.
Do you find, what are your thoughts on like training on a biodex as a, like on top of testing on a biodex?
I mean, I think if you train on the biodex, it could give you like, like you could learn how to do the test better. So your numbers might be better than someone who did it for the first time. But I think training on it could be super cool because there's only one way to get the job done. You have to use your quads and your hams to push and pull. So yeah, that's kind of,
from past experience, I'll tell you, training on it sucks.
Yeah.
It really, really does. It's just your constant effort, right? Because you're pushing at a constant speed. And it can tell if you're cheating because you'll see peaks and valleys that are not consistent with what a normal force curve should be, right? And you start to see some of these things, and it gives data that you're not going to get another way. Mm-hmm. Right. It's not an end all be all as far as a training modality, but it's great to train at variable speeds, right? Especially like some of the hamstrings, when we're in certain positions, moving at speed, we don't get to those unless we're sprinting in another way, right? So it's oftentimes a great way to get that hamstring extended, especially if you bias the hip into flexion a little bit more, and you can train a hamstring in a way that you wouldn't be able to another way to prep for potential sprinting.
Mm-hmm. Yeah. And then Chris, just one other thing on that, like our patients that are part of research won't get to train on the biodex. Like they can only be tested. If they're not in research, then we can use it for training, which I haven't really got to do. So keep y'all posted.
My brain just went to is there a way I could set up the bands in our clinic so that it's pulling both ways and that somebody push and pull? Because that's what I mean. I can't think of many exercises that do.
Do you have the little Velcro ankle bands? Mm-hmm. Okay. I bet you could set something up where you have someone on a tall box and have them be able to kick knee extension, and then have it also attached to something where they could pull down.
Or even manually with a band in one direction, and then stay tuned. I might.
That's your homework for the next
figure it out. Well, because we can attach them. We have little carabiners too, so you get to technically attach the ankle straps to bands, fixate one of them and then do manual resistance with the other one. But that's hard, and I've always thought about potentially being able to do that to help with things like sprinting, like you were talking about, because it's really hard to get, other than starting sprint progressions with people, which I do, but I always think to myself, how can I better prep them for getting to sprinting, especially when I know that push off and TKE sometimes on that surgery side, just they're, we can do plyos and, tempo things during strength things to elicit more power production or whatever. But, having that full hip extension hamstring work in an exercise to prep for sprinting is, I feel like, really difficult to set up in a clinic where we don't have like a ton of space.
What about
Theoretically, I think if you had like furniture sliders and you put plates on them, that would resist, you would have friction in both directions from like a
I see what you're saying.
supine. You could pull them in knee flexion, and then I've never done it or set it up in a way that it worked, because usually when you do those, gravity is letting you go back out, but if it's really heavy, maybe you would have to push it back out.
You would have to push and pull. Yeah, that's true. Yeah, Monday's going to be fun.
Going back to strength testing, I think it was you, Steph, that brought up like percent to body weight. Do you have a cutoff, or are there like normalized values for that outside of?
This is another recent thing that a couple people have brought up to me in general, and that honestly I'm grateful to have gotten the inline dynamometer, because it's data, but it's also making me ask a lot more questions, not just about like, what do these numbers really mean? How much weight am I putting on them? And also, how can I be better to see if we can try to get these numbers better? So I hadn't even before this thought about comparing it to body weight, but I would think that if you're playing a sport where obviously people aren't necessarily wearing a weighted vest when they play a sport, but they might have some partial or all of somebody else's body weight on or near them or perturbing them. Mm-hmm. So I would think that if we're going to play it safe, I would want each limb to at least be able to output body weight. Not necessarily hamstrings, because I know those are always going to be a little bit less than quads, but that's where I even started thinking about it. And then when I tried to find specifics in the research, it was exhausting.
You might be able to regress that back, because it's like 1.6 times body weight in the squat, right, is shown to reduce female risk. Right. There's some literature out there. So figuring out what somebody who can do 1.6 and then figuring out what that symmetry is, and then regress that back to figure out what those ratios may mean in your isometric testing versus that, and that might give you a proxy, at least close enough, right? You'd have to know what the error margin is, but that might give you a proxy estimation of where they are on a squat, even though you may not be able to load them up at that point in time.
Yeah, because the unfortunate reality also in insurance model, an insurance-based outpatient clinic is also, I don't love this, but what is minimum viable product as far as how can I be most helpful and reduce risk as much as I can for this person and set them up to continue to do so after, while still working in the constraints of what insurance will cover, which we still go past that usually, because if you have appropriate ACL rehab, it's not a 6 to 8 week or even a 3 or 4 month. It's like 9+ months. So I think those things are helpful as far as, like you were talking about, Paul, like finding benchmarks / averages that allow you to have more, I guess I would call them KPIs, like key performance indicators, because we are not in a situation where someone could just keep paying me to do one-on-one on-field / in-clinic rehab, where we have other constraints outside of physical and mental constraints. So,
but you can, when you're going back and renegotiating, if you're in an insurance clinic, you can go back and show that you have certain KPIs for certain conditions. Right. And then you can say, hey, I'm going to actually reduce your injury risk. Now, realizing that insurance oftentimes says, well, every 2 to 3 years, somebody's cycling out.
Yeah.
So if I don't have to cover them for the next year after this year, I don't care. Right. But overall to the system, you can argue that you're reducing risk, right? Reducing. Now, if it's government payer, you're they're typical, but that's not who the kids are typically, right?
Right.
I mean,
Right.
there are some federal Blue Cross Blue Shield, but most of them are not. But it's the negotiation of, if I don't get them to some of these key metrics, you may be paying for the next injury.
Yeah.
Right. And so then you can argue a little bit, but you have to have good external data. And we know the paucity of literature out there on some of this stuff, or actually just it's all over the place. We don't have great consistency in some of that stuff, but having some of those data points can help you get some of those others, because I've got to be here. Now, we may not be training consistently, but I can set a program, do some check-ins, and then retest. And then based off of those testings, if they're falling behind, that's another way to reinstigate care. Right at that point, if they're falling off of some of these metrics that they need to be hitting at that point in time, because they may still be under your insurance coverage at that point in time, insurer. So you want to make sure that we're at least able to hit those. So it's a way to use their objective data a little bit against them in some of your arguments at times.
Yeah, and I think we are at a slight advantage as PTs. We can reframe it as risk reduction versus, because I think where we've run into some issues prior to is like really trying to reiterate that they have lingering strength deficits via some of the numbers, but it also has come back to us that that's something they can do with a coach or at a gym versus and be counseled. You know what I mean? So that's what they come back at you with. That's happened to us too. So I think any way we can sort of reframe or add a different KPI could be maybe just,
and just being able to say that part of your program needs to be these retests. So even if it's physical performance tests and they're just coming in and doing that, and if they're falling off of the metrics, their home program or their training with a coach isn't meeting the necessary point. So we need to get invested in them again, and being able to bring them back in at certain points. It's a way to kind of reinstitute that care.
And administer said tests.
Correct.
So pay for
Correct.
it.
Steph, you said normally, like on average, patients are coming in twice a week, but you want like 2 other times a week that they're training on their own. With this situation, how does that look different between in clinic and on their own?
So it has been depending more on what they have access to, because now people aren't going to gyms. So a lot of times one of those other days or both of those other days will be more on the conditioning side or sports specific, like some field work if they're appropriate for that. I ideally would like one other, and most of my kids, I say kids because they're all kids, but most of them do have at least like some dumbbells and stuff at home. So I want one other day of some sort of other than body weight loading. But it's usually obviously not as intense as when they're in the clinic, because we have a lot more access to things. But as soon as either they're running or they have access to something like a bike, or even I've been strategizing with people about going for like fast walks. If they have a heart rate monitor, they can keep track of that, because kids do not believe that they can actually get their heart rate up by walking. But it's a low hanging fruit as far as being a field or court sport athlete, where your aerobic base needs to be there. And then when they are allowed to start running again, it's not so painful. That's what I tell them. Like, I'm giving you this less because I feel like it's going to be fun for you, and more because I know that when we start running more, you're not going to die. So yeah, it's usually either one or two more conditioning side of things. And ideally a third day of some sort of externally loaded workout.
I was going to ask if you do an intake as to where their aerobic base was, right? Okay, could you run a mile or this amount of time and this, just so you have another data point for whether or not you're getting there. Because long, slow cardio sucks, especially for kids that are used to running all over, but they have deconditioned to such a degree that even just having the strength, if we don't have some of the baseline recovery metrics and some of the other stuff in place, we're still setting them up for some of those failures. And so knowing where that is and how do we measure that? There's so many data points within the injury risk mitigation components, right? How do we get all that in a clinic time frame that's meaningful? I mean, that's hard, right?
Yeah, and I hope this is also like a reassurance for some of the younger clinicians too, is like, I this is the majority of my caseload, and I'm still not perfect with all this. Like I can have much better baseline metrics for cardiovascular output and whatever, but I also feel like I've gotten a little bit more forgiving of myself over the last years. Like my next biggest step after we got the dynamometer was to understand how this can best be used in our clinic and how this can best inform my programming and all those kinds of things. So I feel like I'm kind of getting towards not the end necessarily, but I have a good hold on that and we'll build on that. But now I'm thinking like, okay, you know, how do I make sure from earlier on that we're not letting the cardiovascular side of things drop too much? You know, we do some intervals within their sessions and stuff like that, which is great and it's better than nothing. But if you're talking about looking at it more macro, like I could for sure be better at that.
Well, I mean, it's an opportunity cost, right? I mean, are we going to spend 30 minutes trying to get baseline conditioning in the clinic or do I have them do more of that outside? But then how do we track? How do we monitor? How do we know we're progressing? All those things come into the realities of this, right? Which is, again, an argument against the insurance, but those are all bigger things than just.
Yeah, no, it's, I think that's probably where I've fallen into a little bit more of the last year is like, unfortunately, we have 30-minute to an hour sessions if we're lucky. I think we are pretty good at maximizing that time at this point, but it does not really lend itself well to like, okay, at the end of the session, let me take 10 or 15 minutes more to be like, all right, this is what we're going to do on your off day. Like I kind of have to guess a little bit based on what they're telling me. I have some athletes that know exactly, like I would run 3 days a week. That girl I was talking about before knows exactly like what her time was and how often she was running. I'm like, well, first of all, that's too much. But, you know, some people know exactly where they started from, and that helps me as far as building off of that. Most kids, I have to say, their cardio was their sport. So that's a really hard thing to get a measure on, especially when they're, you know, even if they have access to something like a Peloton or they're at a point where they can run. If they've never gone out for a run by themselves or it's been a handful of times, how do you program that? So that's my current $1 million question as far as cardiovascular output.
So Steph, based off the papers you sent us, would you?
We digressed, sorry.
What?
We digressed a little, sorry.
Oh, no worries. Based off like this last paper, is it something that you'd actually consider doing in clinic? And do you think it's meaningful?
I would say that situation that I described with that athlete, it was meaningful. So I think the answer is, as it usually does, it depends. But
what situation?
Where she was more concerned with not feeling it in one side versus the other on her surgery side than I was, because I knew that we were going to have things like SSB squats and some heels elevated and some single leg stuff that was knee over toe that she could tolerate. And all, like, I know all that stuff's in the program and I know what it's there for. She doesn't. So it was concerning to her that she felt like one side was working and the other one wasn't. So in a case like that, and I'm sure there's going to be other cases that arise where I will be thankful to have this knowledge of like, you know, this would be appropriate here. But if people see my current view of things, you know, I always hope that changes in a year or 5 years, but my current view is that if people are shifting a little bit in something like a bilateral task and but the overall motion is good, they're feeling fatigue and a stimulus overall, most often as the weight goes up, as they get a little bit stronger, it tends to just resolve, at least from the naked eye. Like, we know some of that stuff's going to linger anyway. But the short answer is that after reading this, I didn't automatically think like, okay, with every ACL, with every patient who I work with who has gone through an ACL injury, I'm going to forever lift the uninvolved side. If that's what you mean, like, no, that's not necessarily my go-to. But it was just interesting, and I do think it is a patient-specific external constraint.
Steph, would you ever lift the involved side? to balance it out? Because you said, well, I like to do things on both sides. So
yeah, that's a good point. I feel like I can't think of anything right now that I would do that. However, for single leg tasks, I feel like I've had some success with even things like a rear foot elevated split squat, for instance. I have cued people almost to push a little bit into the pad when that surgery side is in the back. It tends to be not a comfortable position. So I know that's not exactly like elevating it, but I do think that even if it was like maybe a half kneel position and that side was on a plate instead of just the ground, and maybe cueing the push under that a little bit more versus the other one could be helpful, as far as like that wouldn't necessarily be external cueing, that would be potentially internal. But I don't know. That's a good question. I can't think of anything as far as like a situation where I feel like I would want to in a bilateral task. Do you have anything in mind?
no, I was just thinking, if we're going to try to even things out,
I see what you're saying.
if we're going to do a set for the involved side,
Yeah.
why not do a set for the uninvolved side? But obviously the purpose is to try to even it out because you're here. So if you do
Right.
something to get it to here, but then you continue raising it in the wrong direction. I mean, that's like the classic, well, should we train the involved side if we have this big deficit? And I think we probably agree, yes, we shouldn't just let that get weaker so that they come here. We should keep it high and bring them the involved side up to meet it,
Yeah, that was actually, I think it might have even just been yesterday, Zach and I were talking about that, because we have one of his patients is, she struggled for a little while with some persistent anterior knee pain and after patellar tendon graft, and also I think some true AMI. And so she basically, the way I view it is like, as far as from quad strength standpoint, one leg was here and was continuing to get stronger. She also had very low numbers in the beginning in general. And this one was like really, 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 really slow. And then she finally started to feel better with loading knee over toe and direct quad loading, close in open chain. And so now they're both going really fast, and she's increasing we've been testing her every 8 weeks. She's been increasing by the same amount, but the ham to quad ratio still looks terrible because the one leg got a head start. So Zach was like, well, do I like chill on the one side and push the other one? And I'm like, my gut says no, because they should eventually, now one up to speed, those curves should then start to come together. But I love having those discussions. Zach and I tend to have them a lot more often because we live together. So, but it makes me always question, right? Like, wait, would that be useful? Or like, so I still, after going through it all, but whether it's a mini existential crisis or not, like, I feel like that's pretty common. And she's 10 months out. And
I think it's probably really common, but people weren't measuring longitudinally before, so they didn't really know what was happening. So it was only at the end. And
to the eye, she's jumping and landing great. She's running. She's playing almost full, but non-contact. I shouldn't say almost full, but I told her, like, I'm okay with you starting that return to sport process at this point. Quad to quad and hamstring to hamstring look good. It's really the only thing at this point is that the ratio, and that's where I also wanted everyone here to understand, like, it's not this rehab is like, I think one of the reasons why I love it so much is because it's really fucking hard. And it's like really long process. It's unique in a lot of different ways. And I don't think it's that uncommon for, especially in young female athletes, but in young athletes in general who have a very low training age as far as strength goes prior to the injury, for them to be in a situation where I don't want them full back before a year, and not because they're not moving well and they're not progressing well, because they actually need that much time to get strong enough and get confident enough. Like, she's 10 months and she's been busting her ass for this whole 10 months. She worked out on her own at home when we were closed for 6 weeks because of quarantine, and like continued to make, even though it was slower, continued to make progress then. But she needs a year. at least. And I would be surprised to see even, adults, high-level athletes that wouldn't also need a similar time frame based on what I know and what I'm seeing right now, especially with the dynamometer. That's been eye-opening. I'm like, yeah, this takes a really long time to not only reach the other side, but oftentimes what we're dealing with is not just reaching the other side, it's getting both sides stronger than they were before.
This example of ACL seems to be really good reason to not trust your eyes with some of these bilateral things. Are there other scenarios in rehab where you're like, I shouldn't be trusting what I'm looking at, or I should test it?
I think hop testing gets a lot of flack. And I don't think that I've ever really viewed it, I think, in the way that maybe research or other people at large or media or whoever wants to debate it has looked at it, because a lot of times people are fixated on the distance and being able to control the landing. But I've always seen it more as like a competency thing. So can they, when they land, do they look confident? Are they wobbling? Does it hurt? And the other thing that I really like them for is, are they landing and their chest is going forward, meaning it's all in their butt and their hip, or are they landing with an upright chest and their knee is bending? And sometimes that's really hard to detect. I'll do like slow-mo on my phone because I won't be able to pick up on it in real time. And I look at this shit all the time. So
I can't believe that people think that they're seeing all that in real time. Because when I've been doing it, I've had a camera in the front and on the side.
Yeah.
And I have to slow it down because there's so many things that you want to look at. Takeoff strategy, landing strategy, knee valgus, hip drop, shoulders. Like, you can't see all that in real time.
Yeah. So I think that hop testing is a really good example. And I honestly, like, I know there was some debate online not too long ago. Some actually like heavy hitters about like, we should just not do it at all. And I staunchly disagree. I don't think that I don't think it is the make or break as far as a return to sport decision for me, but I think it's really good to see where they're at as far as single leg control, force absorption, force production off of that leg. Because one of the things I still struggle with my leg is like, if I have to do anything power related on my right side, I feel like I'm stuck in the mud. It doesn't really hurt, but I can't move quickly off of that side. Not nearly as quickly as the other one. And that's the kind of thing that, like, I feel like if I had done a more organized, progressive plyometric program when I had my rehab, that would be a different story. So I think those are probably ones where I would never trust my eye, because even with slow-mo, I have to watch it like 10 times. I think that's all the questions I had, because I think we ended up talking about some of the ones that I had here in the other. It was kind of leading because both the titles you kind of knew what we were getting at, but
I have one more question.
Other questions?
I have a question about the first paper that I forgot to ask. There was 11 people, and seven of them also had like concurrent injuries, with like, I think 6 had a meniscus tear. Is that normal with ACL tear, like with other things going on? And if not, like, does that change how you'd rehab?
Yeah, it changes more so for early on. So what is common, like what I had was like the triad, so meniscus, MCL, and ACL. Because of the mechanism of injury, it tends to, the two medial joint sources tend to approximate when you get like the valgus mechanism. And obviously that's going to strain MCL as well. So it tends to be those three things. And in that case, if they do a meniscus repair versus just like a partial meniscectomy, then you're non-weight bearing for 6 weeks. And I respect that because the intra-articular areas don't heal well anyway. And that is definitely something I'll follow the surgeon's suggestion on. So that's the only other thing that sometimes sucks if they do a repair versus partial meniscectomy. I was lucky; they just kind of like shaved off part of the outside, and obviously I don't know if lucky is the right word, because now I definitely have a little bit of arthritis. But if they just take out part of it versus repair it, then your weight bearing is tolerated. The other thing I have had some trouble with people is if they have like a posterior lateral corner injury. That just tends to take a little longer, both for full extension to feel okay, for them to actually get back tibial rotation, which is another thing that only in the last like couple years I've been more cognizant of, and weight bearing depending on the surgeon.
Chris, I have, I'm working on a paper for ACL return to play testing, and we had, or my collaborators had 34 people that they tested, and 29 of them had either, well, okay, so 24 of them had meniscus repair, 2 of them had meniscectomy, and 3 had both. So I remember I was talking to the collaborators, and they said, oh yeah, the surgeon likes to do that stuff when he's in there. But I guess the point is that it's very common.
Yeah. Unfortunately, but.
Well, yeah, that's not an insignificant number, Travis. But Steph, I know you have to go soon because you got another call.
This goes so fast.
Yeah, you nailed it. Flying through.
Nerd Saturdays.
Thanks, Steph.
Yeah, I mean, if you guys have other questions or want to nerd out another time, let me know. I'm around. Yes, I do. You're right. I do have a call at 1. But I appreciate you guys, and this is always helpful. I always get something out of, technically supposed to be leading it, but I get just as much out of stuff like this, and I hope you guys do too. So keep at it. Good on you for organizing this, Christopher.
I'm trying. I love how it's like, I call it my school's journal club, but there's very few people in my school that show up anymore. I could just call it like a level up journal club at this point.
Well, maybe they'll be in level up soon. Who knows?
Yeah. All right. Well, thanks again.
Okay.
Thanks
Yeah.
everyone for coming.
Have a great weekend.
Thank
Bye.
you.
Bye.